Hello everyone, my name is Caitlin Tyrrell and today I will be presenting on dysarthria. According to Dr. Catherine M. Yorkston and Dr. David R. Buchelman, dysarthria represents a group of motor speech disorders characterized by weakness, slowness, and/or lack of muscle coordination of the speech musculature as a result of damage to the nervous system. There are 7 different types of dysarthria, and in my presentation I really delved deep into the different symptoms and characteristics of each one. And this is a little advanced for our class, so if you do have time, you could go through each slide and delve into the different symptoms and characteristics for each. But for now, I'm just going to list the 7 different types, which include mixed dysarthrias, and some of the common symptoms between all of them. So first we have flaccid dysarthria, there is spastic dysarthria, ataxic dysarthria, hypokinetic dysarthria, hyperkinetic dysarthria, unilateral upper motor neuron dysarthria, and then there are mixed dysarthrias. And mixed dysarthrias are a combination of 2 or more of the previously mentioned, and they are more common than that of a single type of dysarthria. Some of the most common types of dysarthria are flaccid spastic, ataxic spastic, hypokinetic spastic, ataxic flaccid spastic, and hyperkinetic hypokinetic. Now, when talking about some of the most common symptoms and characteristics of dysarthria, there is muscle atrophy, which is when the muscles are broken down, hypotonia, which is low muscle tone, speech reduced to short phrases, unintelligibility, breathiness, hypernasality, harsh voice, drooling, dysphagia, which is difficulty swallowing, and this is in some clients but not all, tremors, emotionless facial expressions, and slurred speech. There are multiple different anatomical correlates that affect dysarthria. One of these are the muscles that are involved in speech, which is shown in this picture. And there are also a lot of other different structures that can affect dysarthria, which include upper motor neuron system, the lower motor neuron system, the cerebellum, the extrapyramidal system, the basal ganglia, and combinations of all of those above. Now, in the following pictures, I have shown some different examples of different symptoms of dysarthria. In this first photo, it is a good example of facial weakness and lip protrusion. On the photo on the left on this page, this is a good example of an emotionless facial expression, which is a symptom that I mentioned. And the photo on the right shows a dysarthric patient who has tremors, which was also a symptom that I had mentioned. So now I'm going to play a video representation of flaccid dysarthria. As you see in that video, just referring back to the definition, you can see the weakness, slowness, and the lack of coordination of the speech musculature, and you can also see a lot of the different symptoms that I have mentioned. When assessing dysarthria, there are a lot of steps that are involved, and the first step, as with many other diseases and disorders, there's a case history. And underneath of the case history, you must have the old medical diagnosis and the patient's history, the review of previous procedures that have been done, reviewing the medications, family history, and then an overall review of cognitive, auditory, visual, motor, language, and emotional status. After this, there is a non-speech examination that can take place, which could include a cranial nerve exam, observation of the muscle tone, assessment of sustained vowel prolongation, assessment of the AMRs, also known as the alternating motion rates, assessment of speech production, which can include the vocal quality and pitch. You can also do stress testing, which is when a client will read for 2 to 4 minutes, which will allow an assessment of the deterioration over time when speaking. You also must assess prosody, which can be done with speech sampling of connected speech with different pitch, loudness, and duration. Speech intelligibility, which is assessed by a speech sample. Comprehensibility, which can test how much a client understands by a sample with cues. Efficiency, which is by the number of intelligible words per minute. And then swallowing for those clients who do have dysphagia, which are just assessing the function of the structures used for swallowing. The IASCC test for AAC is the Index of Augmented Speech Comprehensibility in Children test. And according to Elizabeth Hansen, this test often demonstrates that even parents have difficulty understanding dysarthric speech without the context of the daily routine, anticipated topics, and controlled conversations. The results from this test helped Sally's parents, and Sally was a child with dysarthric speech. They helped her parents understand that unfamiliar partners who did not know the context of her message would have difficulty understanding. The IASCC test is a great way to assess a child's augmented speech comprehensibility, and it is performed by giving the child multiple words, some topic letter cues, some with only topic cues, and some with no cues, to say, and the clinician would record the child's voice. The recording would then be listened by the children's parents, and the percent of intelligibility to the familiar listener is transcribed. Following this, the same process and percent of intelligibility is written down for the unfamiliar listener hearing the child. When treating dysarthria, there are many different areas that need to be assessed and treated. Respiration is the first area, and inspiratory and expiratory muscle strength training is one way to work on treatment, using optimal breath when speaking, and controlled exhalation tasks can also be used. Regarding phonation, the Lee Silverman voice treatment is very popular, and there's lots of research on that within the ASHA articles. And this works to improve loudness and intelligibility of speech. And then pitch limiting voice treatment, or PLVT, works on increasing loudness but not pitch. In order to work in the area of articulation, you can work on phonetic placement using over-articulation and rate modification, which you can do by using a screen or metronome to show the rate of speaking. Resonance is another area that is worked on, and prosthetic management can be used, including a palatal lift prosthesis or a nasal obturator as some examples. When working on prosody, increasing awareness of respiration, rate, pitch, and loudness of speech are worked on. And then AAC is also a form of treatment. You can use American Sign Language, gestures, communication boards, drawing pictures, or SGDs, which are speech generating devices. An example of a speech generating device, I found some research on voice banking, which I found to be very interesting. And voice banking is being looked into as a new means of providing individuality to SGDs in patients with motor speech disorders like dysarthria. And this is done by recording the voices of people who are the same gender, they may have the same accent or around the same age as those with the MSD, and it allows the client to use their SGD as a form of augmentative and alternative communication. Although this type of AAC is still being trialed and researched, it is a great way to give those with a severe MSD a voice. Conversation-based intervention is also something that I looked into, and according to authors Gloria Soto and Michael Clark, there have been positive effects of the conversation-based intervention for improving the expressive vocabulary and grammatical skills of children with severe motor speech disorders and expressive language delay who use augmentative and alternative communication. This form of treatment was shown to be beneficial for multiple different children with dysarthric diagnosis of some sort, most with coexisting diseases. With speech therapy, this is another form of treatment, and according to Dr. Elizabeth Oman, it is a good idea to continue moving forward meaningfully and integrating speech in the most functional way. In Dr. Oman's article titled Natural Speech and AAC Intervention in Childhood Motor Speech Disorders, Not an Either-or Situation, she explains that natural speech and AAC should both be used if a child is able to use both, and believes that this is the best treatment for those with MSDs depending on their severity. When talking about the application to speech-language pathology, SLPs play a very important role in the lives of those with dysarthria, and some of their responsibilities include screening of potentially dysarthric clients, assessment of dysarthria, diagnosing dysarthria, determining a treatment plan for a client with dysarthria and referring them to appropriate services, collaborating with the patient and family of the client on decisions regarding dysarthria management, providing prevention information for groups at risk for dysarthria, educating others on the needs of a person with dysarthria, and lastly, staying updated on new research regarding dysarthria and using evidence-based practice to guide intervention. Now I have listed all of my references, and thank you so much for listening.